Thank you. I'd like to thank the association for the invitation to speak today. I have no disclosures, but I will say that a lot of what I'm going to talk about is an off-label use for stents in the United States. They are approved for malignant strictures only at this time. The goals of therapy for esophageal perforation, fistula, or anastomotic leak are worth briefly reviewing. Obviously, supportive care, directed antimicrobial therapy, elimination of infection, draining the mediastinum, pleural spaces, etc., preservation of foregut continuity, delivery of nutrition enterally if able, and what we're going to talk about for most of this talk, occlusion of the perforation. Traditional therapy is not perfect, or we wouldn't be looking for something else. Non-operative therapy has narrow inclusion criteria and often results in surgery, only in a delayed fashion. Recent literature from centers with experience in repair of esophageal perforation quotes a 39% leak rate, and that may still increase in patients who have delayed diagnosis. Esophageal diversion, I think most of us would love to avoid that in any patient. 50% of those patients are never reconstructed. There's significant morbidity and mortality associated with that operation. And as you'll see, the patient satisfaction is low in that group. Esophagectomy has a significant mortality and morbidity as well. Anastomotic leak, much the same kind of results. Patients treated non-operatively, 30% will eventually require surgery. Reoperative therapy has a 25% failure rate, and diversion has the same statistics as we just discussed. So esophageal stenting has been around for over 100 years. Improvements in esophageal stent use parallels the biomaterials available, and we're very fortunate in that we live in an era with great biomaterials. These are some of the currently available stents. A lot of our work has been done with the Polyflex stent, but we've used all these. They are thin, they are easily removable, most of them don't fracture, and that's been the impetus, I think, for the increase in the indications for their use. About a decade ago, we started looking at a way to do a hybrid operative and endoscopic treatment strategy for esophageal perforations and leaks. We felt that the ideal treatment would be one that fulfilled those goals we talked about, specifically closure of the perforation, drainage of infection, and maintaining foregut continuity. And as a bonus, if we could do that without a thoracotomy or a celiotomy, we felt that may have a benefit. I'll go very quickly through how we place these stents. That's not the purpose of the talk, but I think it's important for you to hear. We document the leak with an esophagram and then perform a CT scan to look for areas of undrained infection. The stent is placed in the operating room after endoscopy. We use general anesthesia and fluoroscopy. This is all performed by a thoracic surgeon. We also, at that time, perform any associated procedures, VATS, decortication, etc. Occlusion of the leak is documented by esophagram about 48 hours after placement or when the patient can participate. We care for these patients just like they'd had an operative repair of an esophageal perforation. We volume resuscitate them. We watch them closely in the ICU, usually the first night, and the other things that you would normally do in taking care of one of these patients. This is an esophageal or tracheoesophageal fistula treated with a stent. That was actually the first series of patients that we looked at. We looked at patients who had had at least one operative repair for a fistula that had failed. And of 21 patients, we had a successful outcome with stent placement in 20 or 95%. That gave us a little confidence to look at expanding our indications for their use. And the next series we looked at were patients who had an iatrogenic esophageal perforation. 16 of 17 of these patients, we had success with placing a stent for the treatment of their perforation and a reasonable length of stay of a mean of 8 days, which was early in our learning curve. We then looked at what we considered a more difficult patient population, which were spontaneous esophageal perforations. Many of these patients were obese. Many of them had other medical problems. Again, 89% success rate in those patients. That led us to what was kind of the last frontier in our minds, because we had some misgivings about putting stents in fresh anastomoses. And certainly, as many programs have, our leak rate has gone down with new techniques of interthoracic anastomosis, but we certainly still have leaks. And we looked at a group of 17 of those patients placing a stent when we documented an anastomotic leak. And 16 of 17 patients we were able to treat exclusively with a stent, and a 94% success rate, and we've continued to use that and found it very useful. We did look at our failure rate. We looked at our entire series 2 years ago, and that was about 187 patients. We had 15 failures out of that, 8% failure rate, patients who went on to require traditional operative therapy. We felt that that was fairly acceptable early on in our learning curve. Of note, although this is a benign esophageal session, 14 of those patients had associated malignancies in the esophagus, but were not considered candidates for esophagectomy because of other issues. And that surprised us. Those were not the failures, interestingly enough. And just as a quick visual aid, this is an 89-year-old lady, kyphotic, severe COPD, not a candidate for an emergency esophagectomy, perforated just above a distal esophageal carcinoma. You can see our guide wire there across the esophageal lumen. We placed a stent in her. She actually underwent definitive chemoradiation therapy for her malignancy, and then we removed the stent, and this is what she was left with. Recently, we also looked at patients who failed an operative repair. Many of these patients came from other centers, were referred to us after at least one failed operative repair. And we found that placing a stent in those patients was equally successful, similar to the anastomosis. We had some angst in placing stents in patients who had had an operative repair, but it seemed to work well. As we talked to our general surgery residents, you know, this is not a surprise. If trying to sew wet toilet paper together often doesn't work. And if you can do something from the inside to mitigate having to operate on them a second or third time, we found that beneficial. A brief commercial for our paper later this week. We would love to do a prospective randomized trial comparing operative repair with stent placement, but there's multiple reasons it's very difficult to do. The first is it's not an FDA-approved indication. The second is a lot of people don't consider that there's equipoise there right now. And so we propensity matched patients who'd had surgical repair or stent placement for an iatrogenic perforation. A multi-center database was used. And I wanted to highlight one or two of these grids, but they're all, I think, deserving of being highlighted. The mean length of stay, time to oral intake, LTAC admission, and specifically costs were all significantly improved with stent placement. And so when should you stent the esophagus? The bottom line, our current indications: acute perforations and chronic fistulas, an intrathoracic anastomotic leak after esophagogastrostomy, and failed operative repair of a perforation fistula or anastomotic leak. Those are our broad indications. Relative contraindications: a proximal cervical perforation, a perforation that traverses the GE junction, a perforation greater than 6 centimeters in length. We see the occasional transesophageal echo patient with that. And an anastomotic leak associated with a more distal gastric conduit leak. That seems very intuitive, but we have seen that from other programs. And so, in conclusion, esophageal perforation or fistula, we feel, can be effectively treated in the majority of patients using an occlusive esophageal stent as part of a hybrid operative approach. We don't feel these patients should be managed by a gastroenterologist. They should be managed by a surgeon who can fulfill those criteria that we talked about and also recognize a patient who's failed stent placement and take them to surgery. Stent placement for postoperative intrathoracic leak is also successful in the majority of patients. And failed operative repair of those same conditions can often be treated with a stent without reoperation. And I would just leave you with the algorithm that we've put up here before, which is kind of our general thoughts. Thank you very much.